This video will highlight what healthcare delivery looks like in First Nations communities. It will discuss challenges to service delivery such as wage parity, funding, patients being sent away from their community to receive healthcare, mental health and addiction facilities and lack thereof, long wait times, and lack of permanent health specialists on site.
So I think it's important that we look at the landscape of how First Nation Health Services is delivered on reserve. So for people that aren't familiar, the health services responsibility is it's a federal responsibility. So that's much different than how mainstream accesses healthcare in Canada. So the Health Canada First Nations and Inuit Health Branch is the responsible department and branch who looks after the delivery of health services on reserve. So when we look at access on reserve, it goes through a federal role as opposed to the provincial health services. That often creates multi-jurisdictional issues.
Occasionally, I'll get it from the nurses that, okay, you know what? This person has to go to, well, we're from Ontario. Sometimes they come to Manitoba, but sometimes they have issues being seen in Manitoba because they are from Ontario. So, you know, we have those little glitches that the nurses deal with all the time. Some of our biggest challenges come with non-insured. So non-insured, they are responsible for transportation. And sometimes the doctor will say, well, this patient needs to go out and this patient needs an escort. But then non-insured will say, well, no, they don't need an escort. Then the patient will say, well, I don't want to go because I don't want to leave my community without a familiar person with me. So to us, that's a challenge. And it's a judicial challenge because we cannot control that. And then, you know, we have the doctors writing notes, the charge nurses writing notes, and everybody weighing in on that.
I think part of that jurisdictional issue makes it difficult for First Nation health administrators to navigate a world where you're a Canadian that has the right to access health services. However, on reserve, it gets complex because you may go to a provincial partner. So, for example, a client who has services at a mainstream hospital gets discharged, and then the First Nation Health Centre picks it up. There's not that relationship there, and sometimes that's a gap.
Multi-jurisdictional issues that have led to insurance discrepancies have also led to new innovations, such as Jordan's Principle.
With Jordan's Principle, it happened with a child that was trying to access services, and it became who pays. So whether it was the person on reserve, meaning federal money, pays, or the province pays, like in a hospital, like with going off reserve and getting services. So what happened is this child needed to be seen. So they were stuck on who pays, and they ended up forgetting about the child. So the child ended up dying. So because of lack of services. So that was the whole piece, and where everybody needs to understand that Jordan's Principle is about getting services right away without saying who's going to pay the bill. So that's where that came into play.
Jordan's Principle is a brand new, and so it's a new initiative, a 3-year initiative. When the call for proposals came out, we lined up and did our proposal through the Christmas break, prior to the Christmas break, sent it away. We come back after Christmas, there was a nice gift waiting for us. We were successful. We got successful in our Jordan's Principle project.
Communities often struggle over a number of years to get basic services, so patients don't have to travel to larger population centers for healthcare.
And we're continuing to strive for more of the services that are made available to us here in Peguis. One of the most important ones were the dialysis unit that we had brought and negotiated for over a number of years, and it became a reality 4 years ago, which was benefited us really well because our membership didn't have to travel long distances, like say out to Winnipeg and Ashern. So, but and they were housed here at the dialysis unit to receive those services. However, there are some people still continuing to go out to Winnipeg and Ashern.
If I were to share a few insights for non-Native organizations and people working in non-Native health organizations, I would say that the First Nation health environment or the Indigenous health environment requires a level of strength and resilience that you don't often see in other organizations.
The shortfalls is usually where we have it in the home care program, because trying to get all the nurses in. So we had 1 year where we had to hire an LPN versus an RN because we couldn't afford the RN salaries. And then after a while, when we started getting the wage parities, we started able to get in the nurses. So now we're trying to see if we can get back up to par with the home and community care program.
Every day is a challenge. Every day is a challenge. Like I said, the funding issue, you know, whoever gets to see this, I hope that they're decision makers in terms of assisting in getting proper funding. That's key, you know, to make health better in our communities. Listening to our advice, listening to what we say, in terms of especially mental health. There's a huge need for mental health and access to mental health facilities right in our own communities. We lack that.
What healthcare looks like in our community is that we are striving for the best for our community membership, having all the resources available, such as public health nursing, the immunization program, home and community care program. And we have service providers that do come out to Peguis on a monthly basis, and I'm talking about the counseling services. It's a team of First Nations community that counsel membership because of our suicidal rates that we're happening here.
Specialists, we have someone who comes out here for hearing, people who have hearing problems. We have him come out for a day, and whoever needs a hearing device, they can get tested for it, fitted when he comes back. So we have a doctor come out who does that too.
I'm from Toronto, and I worked in bigger hospitals in Toronto, and those things don't really happen in Toronto. You know, you want to be seen, you go to the emerge, you might have to wait 8 hours, but at the end of the day, if the doctor thought you needed a CT, you got that CT within that 8 hours. But here, you know, you'll come, they'll be on the doctor's list to be seen, and the doctor says, well, they need a CT, and it takes 2-3 weeks to get a CT. So whatever is going on with you probably got worse while you waited for that CT. That sort of thing, that's a challenge for me, because it bothers me as a nurse who work in Emerge, and I know that you can get those things done right away. So an ultrasounds, you know, things like that really bothers me. So those are challenges.
Basic infrastructure is a major issue in First Nations communities across the country.
Well, with the infrastructure in our 3 communities, we have some that are falling apart. We need new daycares. So we had 2 bands who went on their own, and they went and applied for dollars on their own and built new buildings, but now those buildings are 15 years old. So now we need renovations, we need upkeep on that, and so we got a little bit of dollars for renovations, but that doesn't help the community that is still suffering, that still has the same building. So even with the daycares plus the health centers, we're still running on the same health centers, and so now with the programs coming into and they're hiring more staff, they're overflowing, so we don't know where to put them.
The answers are multifaceted and never simple. It requires patience, strength, and cooperation.
I think that, so funding is a piece of it. I think too, recognizing that First Nations are capable to deliver the services. I think that culture is an integral role when you look at the delivery of health services on reserve as well.
It's a very fine balance between managing with your community when you often are still dealing with residual trauma and consequences of the challenges that First Nations communities and Inuit communities and Métis communities have faced, and are still dealing with the aftermath of that. So balancing that with integrating best practices and high quality health services, and reaching out to build relationships with mainstream health organizations, because their people access health services not just in the community, but from provincial services and from some federal services. So I think there's a level of strength that First Nation health managers have that just is not always seen in other places. And I think that I would also say the focus on community and family and what it really means to operate in that way. It's not just words, it changes how they operate. So when they're developing programs, they don't develop them on their own, they develop them in combination with the community. They bring in elders to advise, and when the elders speak, they listen. It affects how things are done.
Traditional knowledge is often fundamental to healthcare on reserve, and it requires a First Nation written curriculum provided by organizations such as the FNHMA, the First Nations Health Managers Association.
There may be a patient who is practicing traditional medicine, and we have to respect the choices of an individual patient. So at the core of our program, and it's in the middle where we say, are you, as an administrator on this reserve, aware what the language is? Do you know the traditional history of that geographical area? Is it part of Treaty 4? Is it part of the medicinal chest? Do you understand all the history that's led to why we are where we are in terms of the Indian Act and all of the health services legislation that goes around it? So that was a gap for us, and why we decided let's write our own curriculum so we can incorporate the philosophies of traditional medicine practice, educate on the history of First Nation health service delivery, but still be at a level where we're not watering down our programs. We're actually now accredited by Athabasca University, and we're making those kinds of partnerships with other educational institutions across Canada, and I think that's really key. A person coming into our program really wants the certification for themselves. It's not about transferring knowledge or having a piece of paper on their wall. It's about how can I deliver my health services to the best of my ability and make sure that they're quality. That's the people coming through our program. And for those that want to continue their learning journey, we have created the laddering for them to move into a master's in health administration, where everything they've learned at the FNHMA is transitioned to another academic institution. That's been really successful for FNHMA because people want, not only their own certification by First Nations, for First Nations, but to be acknowledged in mainstream as well.
With traditional knowledge, we have 3 communities within our tribal council. Every single one of them is distinctive in how they run, their communities are. We have one community that's very, very, very traditional, and that's the largest community we have. So everything has to be run through their elders, and when they have issues with leadership, they go to their elders and they answer all the questions. They are the ones that make the decision. Whereas we move to the other communities, one is more church-based, and the other one is also very, it's more in between, it's cultural and church-based.
Traditional knowledge is the biggest piece of healthcare in our community. And this was over 28 years ago that traditional knowledge was brought into our community. We were a divided community at the beginning. Now it's the flow of all the people, all of our community members. Other communities as well come in to receive the traditional healing services by the healer, and also to participate in the, sweat lodges, the naming ceremonies, the traditional healing, the medicine harvesting, the medicine picking, and everything that is incorporated through traditional healing.
There is so much sickness in our people, diabetes, cancers. The foods that we once consumed were very healthy for us, and our bodies were conditioned to those types of food. And because of the rapid change in the last 100 years, I believe that it's exposed us to a lot more illnesses. Not only that, but the other things that happen to our people, which contribute to our physical health, which is the emotional and the spiritual abuses that we've gone through, and it affects our health today. This is our medicine room. This is where we see clients, or when people want to come for traditional medicine, traditional healing, whether it's physical, emotional, spiritual. This is where we do our pipe ceremonies, our naming ceremonies, anything to do with acquiring traditional healing. This is the room that we use. This is where we store all our medicines and the supplies that we need to do the work.
Entities such as the FNHMA assist with a variety of certifications, accreditations, and education for First Nation healthcare providers.
Education, again, is one of my priorities for not only myself but my staff that's under me, because I'm always constantly saying, if there's new courses coming up, say online courses or distance courses, then I encourage the staff, I mentor the staff to make sure that those courses are, they're eligible. If they're eligible for those trainings, then why not? Because that only improves the employees, it improves the outlook of my administration.
We're engaged in intensive training. So what FNHMA is and what we do is we're the national nonprofit organization that certify and offer professional development in First Nation health services delivery. We offer certification and professional development to anyone working with or for First Nation health service delivery organizations in Canada. I also think that First Nation Health is also looking at wage parity and how do we have a qualified workforce where we can retain quality individuals to work within our systems when we don't have adequate funding to pay them. So does certification lend to higher wage and salaries? Maybe, but how do we pull together to ensure that we can be in a competitive market with provincial health authorities, the province, the federal government?
It should be noted that governance is an important aspect of all Indigenous healthcare.
In health services accreditation, our number one recommendation that we see over and over through the accrediting bodies is the governance. Governance in terms of the health organization. We see a lot of communities who are now starting to incorporate as a separate entity from chief and council or band administration. We also see boards being formed, and I think that really goes a long way in ensuring that the health dollars are protected, and protected in the sense that they're being used for the delivery of health services. So governance is really key.
Like so much of contemporary medicine, along with science and applied sciences, the future of Indigenous healthcare largely relies on technology.
I think that's going to be really important, IT for the community. I just went to a conference just recently that was through the AMC, and there's so much stuff that's coming up. One example is they call it a doctor in a box, where you can you have a box and you just the doctor can be seen from there, talked to from there, and it's portable. So you can take this to, if it's therapists or anything like that, take it right to a person's house. That's something that I was really interested in, something that can be implemented. But IT is really important for First Nations as well. The Manitoba First Nation Technology Council is actually going to have fiber, trying to build fiber on all First Nation reserves in Manitoba. So that's going to be exciting. We'll be able to own and operate our own fiber network. We'll be our own ISPs. So we need a lot of young people to be into, ICT positions in the future.
We are going into the electronic record system, which will delete paperwork. So that's something new. It's called Mustimu. Mustimu is an electronic record system out of British Columbia. We purchased an agreement with them. So we started that maybe about 10 years now. So we want everybody within the facility to go electronic records. And the main department here of, say, health records is going to be all turned over into Mustimu electronic record system, which will save us a lot on, say, writing, so it'll be all computerized.
One of our communities has access to telehealth, so they're able to talk with the specialist because they have the Know Your Status program, which is a pilot program that they had started with HIV/AIDS testing, and so what they do is they do a lot of one-on-one with the doctors and when they're doing care. So one of the things that we're trying to do is get that done in the other two communities and at the tribal council, so we can link up services that way. Because a lot of the times with the weather conditions and trying to access, like with the distance apart with the different communities, we want to just have instant meetings and to be more, to be able to work together more. So that's one of the things that we would be able to access telehealth. And the other thing is with special services like speech pathology and all that would be really help us out. With diabetes, we have a special program with the Parkland House, and we work with the doctors there, and our home care coordinator works with a project that they've developed and with the dietitian. So we have clients within the 3 bands that sit in a group, and they monitor and they do case management with them. So that has been running very successful. So they've been adding more clients. This is about the 2nd, 3rd year that they're doing this, and it's been actually pretty successful with that one.
In order to redress the legacy of residential schools and advance the process of Canadian reconciliation, the Truth and Reconciliation Commission made 94 calls to action. Truth and Reconciliation has also helped serve as a bridge between First Nation healthcare and mainstream healthcare. It means different things to different people.
Reconciliation means, for me, that people become healthy again. And so that touches on a lot of areas. I think First Nations communities need to feel strong again and need to feel validated and need to feel that their ways are honored. I think that once this strength comes back, and it is coming back, and I work through my courses, I work with so many powerful, strong First Nation health managers that as our communities get stronger and more people work in health, that I would see reconciliation being more First Nation, more Inuits, Métis, working in mainstream organizations and bringing their culture into mainstream. And it's not threatening. It's not threatening to any side, that cultures are shared because we're all people. And I think anything that divides us hinders reconciliation.
Mental health is a big issue in First Nation communities. We're finally recognizing all the damage that resulted in terms of residential school, decolonization, all of that. We recognize that. Now our people are opening up and wanting to talk about their experiences, their negative experiences, and having done some of that myself, my own personal self-growth and my own healing. You have to talk about your past in order to fix it. You have to acknowledge your past. So that's what's happening. That's what our community members are doing now, and they're seeing the value in that.
Reconciliation in Canada, for me, in my view, is about having an educated society, non-Indigenous, Indigenous, new residents to Canada, but having everyone who knows our history, who is aware, and having culturally safe practices where everyone can have equitable and accessible health services in Canada.
This video has been intended to highlight what healthcare delivery looks like in First Nations and discuss challenges to service delivery such as multi-jurisdictional barriers, human resource issues, as well as funding and wage parity gaps. Of course, this is just a small glimpse into some of the issues surrounding Indigenous healthcare. First Nations are the fastest growing demographic in Canada. First Nations healthcare issues are fundamentally Canadian healthcare issues. Policy, governance, technology, community, in addition to addiction and mental health resources, as well as Indigenous tradition, are just some of what can help build a stronger healthcare system for the First Peoples of Canada. The necessary first step to achieving this is greater education, both for healthcare practitioners and Canadians as a whole. All of these efforts will further narrow the gaps between Indigenous healthcare and mainstream healthcare, and true reconciliation can begin.